Imagine just popping a pimple right on the crease of your nose. I mean,
Yeah.
something people do every single day without even a second thought.
Oh, absolutely. Yeah, happens all the time.
Right. It's just a tiny localized bit of inflammation. It seems entirely harmless, just a millimeter below the skin. But hidden just inches behind that minor blemish is this massive network of valveless, reverse-flowing veins.
Yeah, the plumbing of the human face is, well, it's genuinely bizarre.
It really is. And because of that plumbing, that trivial skin infection actually has a direct high-speed highway straight into the venous pools surrounding your brain. A popped pimple in what clinicians call the danger triangle of the face can, under the right circumstances, lead to a massive clot at the base of the skull, blindness, and potentially fatal meningitis.
It's terrifying when you actually map it out.
It is. So welcome to the deep dive. Today we are not looking at the solid, comforting mechanics of bones and muscles. We are mapping the architecture of empty space.
Which is a really profound shift in perspective, you know? When we study a hinge joint like the knee or, say, the interlocking vertebrae of the spine, we're looking at solid mass. It's binary engineering. Bone meets bone, a tendon pulls a lever.
Right. It's very mechanical, very visible.
Exactly. But the moment we move inward from the facial skin, that whole paradigm shatters. The head and neck region is fundamentally a study of passage. It's a labyrinth of channels, cavities, and connections. The spaces between the bones, the negative space, actually dictate the reality of human survival.
Because things have to move through those spaces.
Yes. Air must be conditioned and moved. Mucus must drain constantly, whether we like it or not. Vast networks of nerves and vessels must transit unseen through these microscopic bony tunnels just to reach the face, the teeth, and the cranial vault.
So we're essentially looking at a system built entirely out of hollows and gaps. And our mission today is to build a spatial and functional mental model of this transit system for you. We need to explore the nasal cavity, which acts as the frontline gateway.
Right, the front door.
Yeah. And then we have to venture into the paranasal sinuses, those hollowed-out vulnerabilities that cause, well, so much human misery during cold and flu season. But we can't really understand the periphery without understanding the core. There is a hidden hub that connects everything, a tiny, almost forgotten pyramid of negative space called the Pterygopalatine Fossa.
Yeah, to understand the face, the airway, and the palate, we really have to start in that hidden hub. The guiding philosophy for our analysis today is the study of structure in service of function, and crucially, how that very specific, highly adapted structure ultimately shapes disease, dictates medical intervention, and determines patient outcomes.
And the Pterygopalatine Fossa is the ultimate embodiment of this, right?
It really is. It's a silent crossroads where air, sensation, and secretion all converge.
Okay, but the name alone is a huge barrier to entry. Pterygopalatine Fossa, it's a mouthful. Let's ground this spatially before we talk about what it actually does. If I take my finger and press it against my cheekbone, where exactly is this space? How deep are we talking and how big is it?
Okay, so if you press against your cheekbone and imagine a line projecting straight back, maybe about 1.5 inches deep behind the upper jaw, you'd find it. Geographically, it's a very small, inverted, pyramid-shaped space. We are talking about a volume no larger than a small teardrop.
Wait, a teardrop? That's tiny.
It is incredibly small, and it is squeezed, and I mean intensely compressed, between 3 surrounding bony structures. Anteriorly, you have the posterior wall of the maxilla, which is your upper jawbone.
Right.
Posteriorly, there's the pterygoid process of the sphenoid bone, which sits deep in the skull base. And medially, so toward the midline of your face, it's walled off by the perpendicular plate of the palatine bone.
So 3 distinct bones approximate each other, but
Yeah.
they fail to fuse completely. They basically leave a teardrop-shaped void.
Exactly. And, biology abhors a true vacuum, so this bony gap becomes the staging ground, the grand central station, really, for the neurovascular structures of the deep face. It communicates directly with the orbit, the nasal cavity, the oral cavity, the middle ear, and the superficial face.
All through a teardrop.
Yeah, all through an incredibly dense series of tiny canals, fissures, and foramina. If you trace any major neurovascular cable in the midface, it almost certainly routes through this microscopic closet.
Okay, let's trace the plumbing first then. The vascular hub. We're looking at a massive blood supply entering a space the size of a teardrop.
We are tracking the maxillary artery here, specifically the third portion, which is also known as the pterygopalatine portion.
Yeah.
The maxillary artery itself is a major terminal branch of the external carotid.
Right, coming out from the neck.
Yes. It leaves the deep face, navigates the infratemporal fossa, and sneaks into our little server room via a literal doorway called the pterygomaxillary fissure.
I'm picturing a thick main water line, entering a utility closet, and immediately splitting into a dozen different pipes going to completely different rooms.
Yeah.
So where does this blood actually go?
That's a great analogy because the moment it crosses the fissure, it explodes into a network of highly specialized branches. We really have to trace these to build the 3D model. So let's look at the posterior superior alveolar artery first. It branches off right as the main vessel enters the space.
Okay, where's that one heading?
It travels downward, resting on the maxillary tuberosity, that's the rounded bony bulge just behind your last upper molar, and then it dives directly into the bone itself.
Which means it's supplying the back teeth.
Exactly. It supplies the maxillary sinus lining, the upper molars, the premolars, and the surrounding gingiva. Any dental procedure involving those back teeth absolutely relies on the vitality of this specific arterial branch.
Okay, so that's the downward branch. What about the rest of the main trunk?
From there, the main trunk of the maxillary artery presses forward. It leaves the fossa and enters the floor of the eye socket, the orbit, through the inferior orbital fissure. And at this point, it gets renamed. It's now the infraorbital artery.
Traveling directly under the eyeball. I mean, that seems like an incredibly vulnerable transit route.
Oh, it is. It's entirely exposed to orbital floor fractures, which are often called blowout fractures. Those occur with blunt force trauma to the eye, like a punch or a baseball.
Wow. And the artery is just sitting right there in the fracture zone.
Yeah, it travels within the infraorbital groove, which eventually closes over to become a bony canal before popping out onto the front of the face through the infraorbital foramen just below the pupil.
That's quite a journey.
It is. And along this perilous path, it sends orbital branches upward to the lacrimal gland, the Pyrrh gland, and to the extraocular muscles like the inferior oblique and inferior rectus. It also drops branches downward called the anterior superior alveolar branches.
Let me guess, those supply the front teeth.
You got it. They tunnel through the front of the jaw to supply your incisors, your canines, and the anterior wall of the maxillary sinus.
So it threads a needle under the eye just to reach the front teeth and the cheek. That is wild. Okay, so we've covered the back teeth and the front face. What about the roof of the mouth? The palate is highly vascular. I mean, I know that from burning it on hot pizza and feeling the pulse there.
Yeah, everyone knows that feeling. That intense vascularity comes from the greater and lesser palatine arteries. These vessels drop straight down from the floor of the Pterygopalatine Fossa. They travel vertically through the Pterygopalatine canal, descending through the bone until they emerge via foramina onto the hard palate.
And then they just spread out.
Yes. The greater palatine artery rushes forward to supply the hard palate and palatal gingiva, while the lesser palatine heads backward to supply the soft palate and the tonsillar region. The rapid healing you experience after burning your palate is entirely due to the robust blood flow from these descending vessels.
Okay, so we've mapped downward and forward. The architecture of this space suggests there must be pathways heading backward toward the throat and inward toward the nasal cavity as well.
Absolutely. Heading backward, or dorsally, we find the pharyngeal branch. This slender vessel passes through the pharyngeal canal to supply the auditory tube, the sphenoidal sinus, and the upper reaches of the pharynx.
Makes sense.
And there's also the artery of the pterygoid canal passing through the posterior wall to feed similar structures, extending all the way into the middle ear. But the most critical branch for our discussion of the nasal airways heads straight medially.
Going completely sideways into the nose.
Right. That's the sphenopalatine artery. It exits the fossa medially through the sphenopalatine foramen and just bursts into the nasal cavity. This artery is the primary blood supply to the vast, complex mucosal linings of the nasal fossa.
So it's supplying all that tissue inside the nose.
Exactly. Its terminal branches create an immense capillary bed that we will examine very closely when we talk about epistaxis or severe nosebleeds a bit later on.
So we have 6 major arterial branches radiating from a teardrop of empty space. The teeth, the face, the palate, the throat, the ear, and the nose are all fed from this one hidden junction.
It's an incredible distribution network.
It really is. So that covers the blood, the biological power supply. But, a server room is primarily about data.
Let's look at the neural hub. We are dealing with the maxillary nerve, the second division of the trigeminal nerve, commonly referred to as V2.
Right. So the trigeminal nerve is the great sensory apparatus of the face. And V2 is purely, unequivocally, a sensory nerve. It does not control muscle movement. Its sole function is to carry information regarding touch, pain, and temperature from the facial structures back to the central nervous system.
Okay, so how does it get into our teardrop space?
It enters our pterygopalatine space from the posterior aspect, arriving directly from the middle cranial fossa through a circular bony tunnel called the foramen rotundum.
So this massive sensory cable enters through the back wall, and I'm assuming, just like the artery, it has to splinter off to cover all that territory. It follows a strikingly similar distribution pattern, actually. Once inside, V2 gives off the zygomatic nerve, which heads upward into the orbit to supply sensation to the skin over your cheekbone and temple. It also drops the posterior superior alveolar nerves downward.
Let me guess, accompanying the artery the same name.
Exactly, to gather sensory data and, crucially, pain signals from your upper molars.
And the main trunk continues forward under the eye, just like the blood vessel.
Yep, plunging through the inferior orbital fissure to become the infraorbital nerve. It travels the exact same perilous groove and canal as the artery, eventually emerging onto the face to provide pure sensation to the lower eyelid, the lateral side of the nose, and the upper lip.
So if a dentist injects local anesthetic right there.
If they inject at the infraorbital foramen, that entire quadrant of the face goes completely numb.
Okay, but I am struggling with a functional paradox here. We just established that the maxillary nerve, V2, is purely an input cable. It only feels things. It does not output commands.
Right. It's afferent only.
But sitting right alongside it in this tiny, bony closet is the pterygopalatine ganglion. And this ganglion belongs to a completely different system. It's part of the facial nerve, cranial nerve 7.
Ah, yes. It is a profound structural quirk. The pterygopalatine ganglion is a parasympathetic ganglion. It belongs to the autonomic nervous system. Its function is secretomotor, meaning it sends output commands telling glands to secrete. It is responsible for making the lacrimal gland produce tears and the mucosal glands of the nose and palate produce mucus.
Okay, but why is an output module for the facial nerve sitting inside the sensory hub of the trigeminal nerve? The facial nerve doesn't even enter this fossa directly.
No, it doesn't. And it is perhaps one of the most elegant architectural hacks in human anatomy. So the facial nerve originates the secrete command back in the brainstem. The preganglionic parasympathetic fibers travel a really labyrinthine path through the temporal bone, eventually forming the nerve of the pterygoid canal, which enters the posterior wall of our fossa.
Okay, so the signal gets into the room.
Right. These fibers enter the pterygopalatine ganglion and synapse. They physically connect and hand off the signal to the next neuron in the chain, the postganglionic cell body.
So the command to cry or to produce mucus has arrived in the server room. But the facial nerve doesn't have any physical cables leaving this room to actually reach the eyes or the nose.
Exactly. It lacks the physical distribution network. It has the command, but no wires to deliver it. The maxillary nerve, however, has this massive, sprawling, perfectly routed sensory network going exactly to the eyes, the nose, and the palate.
Wait, so what do they do?
So the postganglionic secretomotor fibers of the facial nerve simply hitch a ride. They physically merge with the sensory branches of V2.
That is amazing. It's biological carpooling. They hop onto a completely different train line just because it's heading to the right station.
It is the ultimate example of structure dictating function. The sensory nerve provides a structural highway for autonomic motor fibers. When emotional or physical stimuli trigger the brain to produce tears, the signal travels out via the facial nerve, synapses in the pterygopalatine ganglion, jumps onto the maxillary nerve's zygomatic branch, and rides it upward into the orbit, eventually reaching the lacrimal gland.
And I assume the same thing happens for a runny nose.
Yep, the exact same piggybacking occurs with the nerves descending to the palate and the medial branches entering the nasal cavity. The secretomotor fibers hitchhike on the sensory nerves to activate the mucosal glands.
So literally every time a person cries or their nose runs during a sudden drop in temperature, we are witnessing this neurovascular server room in action. The signals are routing through a tiny hidden pyramid behind the cheekbones, utilizing a shared infrastructure.
The proximity of these diverse nerves within this highly confined space is entirely in service of the function of getting those autonomic signals to the mucosal surfaces of the face.
That completely reframes the entire concept of facial anatomy for me. The face is not just a mask. It's a display screen for all this hidden wiring. Let's step out of the server room now and examine the front line where these secretions are actually deployed. The nose, the gateway to the corridors.
The nose is fascinating because it holds a really unique position. It is the only portion of the respiratory system that protrudes externally from the body contour.
Let's trace the external morphology. because the physical shape actually dictates the airflow. Between the eyes, we have the root. Moving downward is the bony bridge, which transitions into the dorsum, the main slope of the nose.
Right.
The tip, which is the fleshy, movable bulb, is the apex. The openings themselves are the nares, separated by a midline strip of tissue called the columella. Flanking the nares are the fleshy, flared sides, known as the ala.
And, the external shape is highly variable from person to person, but the functional intake mechanism is remarkably consistent. The moment air crosses the threshold of the nares, it enters the vestibule. And unlike the rest of the respiratory tract, the vestibule is lined with highly modified skin, not mucosa.
Okay, why skin?
Because the skin contains a dense concentration of sebaceous glands and vibrissae.
Vibrissae being the highly technical anatomical term for nose hairs.
Exactly. Short, thick, bristle-like hairs. They form a literal thicket in there, and their function is purely mechanical. They act as the body's primary environmental strainers.
So catching the big stuff.
Right. Before air can access the delicate internal pathways, it must pass through this physical mesh, which catches large particulate matter dust, pollen, insects. And the sebaceous glands coat these hairs in oil, which increases their trapping efficiency.
Beneath that skin, though, the architectural framework is a hybrid. It's not a solid bony protrusion because, well, if it were, every minor fall to the face would shatter the skull.
Yeah, the skeleton of the nose is a masterclass in varied material properties. The root and the bridge are rigid. They are formed by the paired nasal bones, which articulate securely with the maxilla laterally, the frontal bone superiorly, and the ethmoid bone deep within.
But the lower half is completely different.
Yes, as you progress downward toward the apex, the skeleton transitions entirely to hyaline cartilage.
Which gives it that flexibility. I mean, you can press the tip of your nose flat against your face and it springs right back.
There are 5 principal cartilages creating this lower framework. The largest is the median nasal septal cartilage, which is a flat vertical plate defining the midline. Flanking it are the paired lateral nasal cartilages, which form the structural sides of the dorsum. But the most critical from an airflow perspective are the greater alar cartilages.
Those are the ones that loop around the nostrils, right?
Correct. They form a distinct C shape, providing the lateral and medial skeletal walls of the nares. And this C shape is not merely aesthetic, it's a critical functional adaptation. It actually acts as a physical, spring-loaded stent.
A stent. How so?
Think about it. When you take a sharp, deep breath, you create negative pressure inside the nasal airway. If the nares were composed only of soft tissue, that negative pressure would cause them to collapse inward, sealing off the airway entirely. The greater alar cartilages physically hold the door open against the vacuum.
That makes perfect sense.
Okay.
So once we pass the stented doorway of the nares, we enter the internal nasal cavity proper. This space is divided into a right and left fossa by the median nasal septum. Now, you mentioned the septal cartilage, but the septum goes much deeper than the fleshy part of the nose.
Oh, yes. The internal septum is a composite wall. Anteriorly, it's the flexible median nasal septal cartilage. But as you trace it backward and deeper into the skull, it transitions into rigid bone.
Which bones?
The upper posterior expanse is formed by the perpendicular plate of the ethmoid bone, dropping vertically from the cranial floor. The lower posterior expanse is formed by the vomer, which is a distinctive plow-shaped bone rising from the hard palate. So together, this cartilage and these two bones form a flat vertical partition.
Flat in theory, but rarely flat in reality. Which brings us to a massive clinical reality.
Yeah.
The deviated septum. Whether it's a congenital growth asymmetry or the result of a physical impact like sports or an accident, the septum is frequently pushed off the midline.
Yeah, a perfectly straight septum is actually an anatomical rarity. Most minor deviations are entirely asymptomatic. People don't even know they have them. The clinical threshold is crossed when the anatomy begins to dictate pathology.
What does that look like?
If the septum is displaced to such a degree that it mechanically narrows one nasal fossa, or worse, physically impacts the lateral wall of the cavity, the whole system fails.
But how does just physical contact inside the nose cause systemic failure?
By 2 main mechanisms. First, the airway volume is structurally compromised. This forces the patient to rely heavily on mouth breathing, which entirely bypasses the air conditioning functions we're about to discuss. And that leads to dry mouth, poor sleep architecture and chronic fatigue.
Right. And the second mechanism.
Second, the point of physical contact between the septal mucosa and the lateral wall mucosa creates a zone of chronic friction and irritation. The tissue responds with localized inflammation, swelling, and a total disruption of the normal mucociliary clearance. Mucus just pools in this narrowed space.
Which is a bacterial playground.
Exactly. Stagnant mucus at body temperature is an ideal culture medium for bacteria. The structural deviation essentially guarantees a cycle of chronic, recurrent sinusitis.
So the anatomy traps the patient in a disease loop. And the only way to break the loop is structural intervention, physically excising the deviated bone or cartilage in a septoplasty. Okay, so the medial wall, the septum, is meant to be flat. But the lateral wall, the outer wall of each nasal fossa, is a chaotic, projecting landscape.
The lateral wall is arguably one of the most complex bony topographies in the human body. It is specifically designed to maximize surface area within a confined volume. Jutting out from the lateral wall into the airway are 3 scrolled laminae of bone. We identify them as the superior, middle, and inferior nasal conchae, widely known in clinical practice as the turbinates.
Turbinates. I always picture the aerodynamic spoilers or baffles inside a high-performance engine. They aren't random protrusions. They are highly calibrated aerodynamic disruptors.
That is the perfect conceptual model. If the nasal cavity were just a smooth, unobstructed pipe, inspired air would shoot directly back into the pharynx and down into the lungs in its raw environmental state.
Which the lungs wouldn't like.
Not at all. The delicate alveoli of the lungs cannot tolerate cold, dry air. It causes immediate bronchospasm and damages the gas exchange interface. The air must be aggressively conditioned.
So the turbinates force the air to interact with the environment of the nose.
Yes, they shatter the linear laminar flow of incoming air, converting it into a turbulent vortex. The air is forced to swirl and eddy around these projecting, scrolled bones, and the bones are not bare. They are cloaked in a thick, highly specialized, hypervascularized respiratory mucoperiosteum.
Basically a biological radiator.
A radiator, a humidifier, and a centrifuge, all operating simultaneously. The turbulent air is thrown against this vast mucosal surface area. Venous plexuses within the mucosa radiate heat, rapidly warming the air to core body temperature.
That's incredible.
And the continuous sheet of mucus evaporates moisture, humidifying the air to nearly 100% relative humidity before it ever reaches the throat. Simultaneously, the centrifugal force of the turbulence throws microscopic dust particles, allergens, and bacteria outward, slamming them into the sticky mucus layer where they are trapped.
The engineering is staggering, and the tissue itself changes depending on where you look, right?
Mhm.
Most of this radiator is pink or deep red because of the intense blood supply. But right at the very top, the ceiling of the nose, the color actually shifts.
Yeah, superior to the uppermost concha, right at the vault of the nasal cavity, the respiratory mucosa transitions to a yellowish-brown tissue. This is the olfactory mucosa. This is the domain of the special sense of smell.
How does the air get up there?
The turbulent airflow created by the turbinates ensures that a specific fraction of every single breath is drafted upward to this high ceiling, allowing odorant molecules to dissolve in the mucus and bind to the specialized nerve endings of the olfactory nerve.
So the turbinates control the climate and direct the air for smelling, but they also conceal an entirely different, highly vulnerable system. Tucked underneath the overhang of each concha is a sheltered space called a meatus.
The meatuses function as protected anatomical harbors, and within these harbors lie the precise, pinpoint openings, the ostia through which the massive paranasal sinuses drain their constant production of mucus into the nasal cavity. The lateral wall is literally the drainage board for the entire deep face.
We really need to map these exact drainage coordinates, because when these pinpoint openings block, the resulting pressure and infection drive millions of clinical visits every single year.
We do. Starting at the highest point, located posterior and superior to the superior concha, is the sphenoethmoidal recess. This isolated location is the exclusive drainage site for the sphenoidal sinus, which sits deep within the skull base.
Okay, moving down.
Moving down, tucked directly beneath the superior concha, is the superior meatus. This harbor receives the drainage from the posterior ethmoidal air cells.
Those are relatively straightforward, but as we descend to the middle meatus, underneath the middle concha, the anatomy becomes alarmingly congested.
The middle meatus is a massive structural bottleneck. If you were to surgically remove the middle concha to view the wall beneath it, you would see a complex bony relief. there's a prominent rounded bulge called the ethmoidal bulla, which is actually formed by the middle ethmoidal air cells pushing outward into the nasal cavity.
Okay.
And just below and anterior to this bulla is a delicate, sickle-shaped ridge of bone called the uncinate process.
It sounds like geographical features on a map. The bulla and the uncinate process, what lies between them?
Between the bulging bulla and the curving uncinate process lies a deep, crescent-shaped groove known as the semilunar hiatus. This microscopic anatomical gutter is arguably the most critical drainage site in the head.
Why is it so critical?
Because everything drains there. The anterior ethmoidal air cells drain into it, the massive maxillary sinus empties its entire volume into it, and frequently the frontal sinus, draining down from the forehead via the frontonasal duct, funnels directly into the anterior portion of this exact same hiatus.
Wait, 3 entirely separate massive sinus systems are all forced to drain into one tiny crescent-shaped slit? I mean, that is a catastrophic design flaw waiting to happen.
It is a profound vulnerability. Because of this convergence, if a patient develops a simple viral upper respiratory infection, the mucosa lining the middle meatus becomes inflamed and swollen. That edematous tissue can easily swell shut, completely obliterating the semilunar hiatus.
And then what?
In an instant, the drainage pathways for the frontal, maxillary, and anterior ethmoidal sinuses are simultaneously clamped off. The trapped mucus stagnates, pressure builds, and a broad-spectrum multi-sinus infection ensues.
So the architecture basically sets the trap. Just to complete the map, below the lowest bone, the inferior concha, we have the inferior meatus. I assume more sinuses drain there.
Actually, no paranasal sinuses drain into the inferior meatus. It receives a single distinct structure, the nasolacrimal duct.
The tear duct.
Yes. This duct transports excess lacrimal fluid tears from the conjunctival sac of the eye down into the anterior aspect of the inferior meatus. This anatomical pathway perfectly explains the universal phenomenon of developing a runny nose while crying. The excess tears simply overwhelm the evaporation capacity of the nose and drip right out the nair.
We've mapped the walls and the harbors. The boundaries of this space are just as vital. Let's look at the floor and the roof.
The floor of the nasal cavity is simultaneously the roof of the oral cavity. It's formed by the palatine process of the maxilla anteriorly and the horizontal plate of the palatine bone posteriorly. At the very front, just behind the central incisors, is the incisive canal, which transmits nerves and vessels communicating between the nose and the palate.
And the roof.
The roof is a narrow, highly concave vault. The central horizontal portion is formed almost entirely by the cribriform plate of the ethmoid bone.
The cribriform plate. That structure is going to be the focal point of a truly terrifying clinical scenario later on. But we have walked through the gateway, analyzed the air conditioning baffles, and located the drainage gutters. It's time to venture into the hollowed vulnerabilities themselves. Section 3. The paranasal sinuses.
The paranasal sinuses are extensive, air-filled cavities hollowed out within the maxilla, frontal, ethmoid, and sphenoid bones. They develop as outpouchings of the nasal cavity during gestation and early childhood, which is why they are entirely lined with the exact same respiratory mucosa and why they remain connected to the nasal cavity via the minute osteo we just mapped.
Before we look at the individual sinuses, we have to address the evolutionary mystery here. Why do human beings have massive empty spaces inside their skulls? The traditional textbook answers usually claim they evolved to decrease the weight of the head or to act as resonating chambers to amplify the voice. Do those actually hold up?
If we critically examine the source literature, both of those classical theories collapse under biomechanical and comparative analysis. Let's evaluate the weight reduction theory first. The assumption is that without hollow sinuses, the skull would be too heavy for the neck musculature to support.
Sounds logical on the surface.
It does, but it ignores bone histology. If the sinuses failed to develop, those spaces would not be filled with dense, heavy cortical bone. They'd be filled with spongy, honeycombed, cancellous bone and marrow, which is incredibly light. The actual mass difference between a hollow sinus and a marrow-filled space of identical volume is functionally negligible. It would not alter the biomechanics of head posture in any meaningful way.
So the weight theory is essentially a myth. What about vocal resonance? I mean, they look like the inside of an acoustic guitar.
Acoustic logic suggests they should amplify sound, but biological evidence contradicts it. Many mammalian species that rarely or never localize possess highly developed, extensive paranasal sinus systems. Furthermore, in clinical practice, when a human patient presents with severe pansinusitis, where the sinuses are completely engorged and filled with thick, purulent fluid, which effectively obliterates any resonant acoustic properties, their core ability to phonate and articulate speech remains intact. Their voice might sound nasal or muffled due to the swollen tissue blocking the main nasal airway, but the fundamental mechanics of speech are not destroyed.
So if they don't lighten the skull and they aren't vital for speech, what is their purpose?
The rigorous anatomical truth is that their primary evolutionary function remains largely unknown. Hypotheses range from providing a localized immune buffer to playing a role in the intricate growth patterns of the facial skeleton to simply being an evolutionary byproduct structural dead zones left behind as the face evolved to accommodate shifting dental and orbital demands.
Well, functionally, regardless of why they exist, their anatomical reality is pretty stark. They are large enclosed spaces lined with mucosa that constantly secretes mucus, which must be continuously swept by microscopic cilia toward tiny, easily obstructed exit holes.
They are structural liabilities, without a doubt.
Let's examine the largest liability of them all, the problem child of the face, the maxillary sinus. It occupies virtually the entire body of the maxilla, sitting right beneath the cheekbones and the orbits.
It is a massive pyramidal-shaped cavity, and its internal architecture features what can only be described as a catastrophic design flaw from a fluid dynamics perspective.
Explain the flaw.
Right.
This is the one that gets everyone.
Consider the drainage pathway. The maxillary ostium, the singular exit hole, is located high up on the supraremedial wall of the sinus cavity. It drains upward into the ethmoidal infundibulum of the middle meatus.
It drains upward. The drain is literally at the ceiling.
Precisely. Imagine designing a bathtub where the drain is located an inch below the upper rim rather than at the floor. For the maxillary sinus to clear its daily production of mucus, it cannot rely on gravity. The fluid must be actively hauled upward against the force of gravity entirely by the microscopic rhythmic beating of the mucosal cilia.
And if those cilia stop working,
If those cilia are paralyzed or slowed down by a viral infection, cold air, or chemical irritants like tobacco smoke, the clearance mechanism simply halts. The alternative is that the sinus must physically fill with fluid until it reaches the level of the ostium and overflows, or the patient must lie down on their side to allow gravity to assist.
it's an evolutionary hangover from when our ancestors walked on all fours, isn't it? If your head is down, the ostium is at the bottom. But the moment we stood up on two legs, the drain ended up on the roof. No wonder the maxillary sinus is the epicenter of chronic sinusitis. A minor swelling at the ostium traps a massive pool of stagnant fluid at the floor.
Stagnation breeds infection, but the clinical peril of the maxillary sinus extends far beyond congested breathing. We really must examine the floor of this sinus. The inferior wall of the maxillary sinus is intimately, sometimes terrifyingly, related to the roots of the maxillary teeth, specifically the first and second molars.
How close are we talking?
In many adults, the roots of these molars project upward, forming distinct, visible bony mounds in the floor of the sinus. In some cases, there is no intervening bone at all. The apex of the tooth root is separated from the hollow sinus cavity only by the microscopic thickness of the mucous membrane.
Which explains one of the most confusing patient presentations in primary care. A patient gets a head cold. A few days later, they develop excruciating, throbbing pain in their upper back teeth. They sit in the dental chair, convinced they need a root canal. The dentist taps the teeth, takes a radiograph, and declares the teeth are perfectly healthy. The diagnosis is sinusitis. How does a sinus infection perfectly mimic a catastrophic toothache?
We have to recall the neural wiring from the Pterygopalatine Fossa we discussed earlier. The maxillary nerve, V2, gives rise to the posterior superior alveolar nerves. These sensory cables travel down through the bone. Crucially, they branch to supply sensory innervation to both the mucosal lining of the maxillary sinus floor and the dental pulps of the molar teeth.
Oh, wow, so they share the cable.
Yes. The brain receives an intense pain signal traveling up this shared bifurcated neural pathway. Because the human brain is evolutionarily conditioned to interpret severe pain in this region as dental pathology rather than mucosal inflammation, it misinterprets the origin of the signal. It refers the pain from the swollen sinus directly into the healthy teeth.
The shared anatomical wiring creates a highly convincing sensory illusion.
Precisely.
But this proximity is not just a sensory trick. It creates mechanical nightmare scenarios during dental surgery as well.
It's a massive surgical risk. Imagine a scenario where a maxillary first molar is extensively decayed, structurally compromised, and requires extraction. The dentist must apply controlled force to elevate the tooth. But because the roots are practically or literally inside the sinus cavity, excessive upward force or an attempt to dig out a fractured root tip can easily punch a hole directly through the fragile sinus floor,
So the root breaks through into the empty space above.
creating an oroantral communication. This is a direct, open physical tunnel between the bacteria-rich, unsterile environment of the oral cavity and the sterile, enclosed environment of the maxillary sinus.
That sounds horrific.
It is. Every time the patient swallows, eats, or speaks, oral contents and flora can be forced upward into the sinus. It guarantees a massive, putrid, and incredibly difficult to treat sinus infection. A fresh communication requires immediate surgical intervention, often utilizing soft tissue flaps to seal the breach. It underscores why rigorous radiographic analysis of the root-sinus relationship is an absolute prerequisite before extracting any upper molar.
Always respect the negative space above the teeth.
Yeah.
Okay. Moving upward from the cheeks, we encounter the frontal sinuses, situated within the frontal bone of the forehead, directly above the orbital margins.
These spaces pneumatize the forehead. They are highly variable in size and shape, usually divided by a bony septum that is rarely midline, resulting in asymmetrical left and right cavities. Now, unlike the maxillary sinus, gravity works in their favor. They drain downward, utilizing the frontonasal duct to empty into the anterior middle meatus.
They have gravity on their side, but when they do fail and become infected, the anatomical relationships make it incredibly dangerous.
The danger lies in the venous drainage. The venous networks surrounding the frontal sinus communicate intimately with the diploic veins running within the spongy core of the skull bones. These, in turn, connect with the dural venous sinuses, the massive blood channels surrounding the brain itself.
So the infection can travel inward.
Yes, if a frontal sinusitis is severe and left untreated, the purulent inflammation can easily track backward along these venous pathways, resulting in frontal bone osteomyelitis, an aggressive infection of the skull bone, which can rapidly progress inward to cause meningitis or a frontal lobe brain abscess.
A sinus headache that eats into the skull. That's bleak. Deep behind the frontal sinuses, almost perfectly in the center of the skull base, are the sphenoidal sinuses.
These hollow out the body of the sphenoid bone. They're also asymmetrically divided. They drain anteriorly into the sphenoethmoidal recess, and their clinical significance largely stems from their location. They sit directly inferior to the sella turcica, the bony saddle that houses the pituitary gland.
Which makes them a surgical thoroughfare.
Exactly. Neurosurgeons exploit this anatomical empty space in a procedure called a transsphenoidal hypophysectomy. To remove a pituitary tumor, rather than opening the cranial vault and navigating around the brain, the surgeon passes instruments up through the nasal cavity, breaks through the anterior wall of the sphenoidal sinus, crosses the empty sinus cavity, and breaches its roof, arriving directly at the pituitary gland.
The sinus acts as a natural hollow corridor to the center of the brain. That is brilliant. Finally, situated between the sphenoid behind, the nasal cavity medially, and the orbits laterally, we find the ethmoidal sinus. But looking at the diagrams, it's not a single open chamber like the others.
No, the ethmoidal sinus is much more accurately described as the ethmoidal labyrinth. It is a honeycombed network of thin-walled, interconnected bony air cells categorized into anterior, middle, and posterior groups based on their drainage. The posterior cells drain into the superior meatus, while the middle and anterior cells crowd into the middle meatus.
A honeycomb of delicate bone. And the lateral boundary of this honeycomb presents a terrifying clinical correlation.
Yes. The lateral wall of the ethmoidal labyrinth simultaneously forms the medial wall of the orbit, the eye socket. The bone separating the infected mucus of an ethmoidal sinusitis from the delicate tissue surrounding the eyeball is called the lamina papyracea. That Latin term translates literally to paper-thin layer.
A paper-thin sheet of bone is all that separates a common cold from the eye.
It is shockingly fragile. In cases of severe aggressive ethmoidal sinusitis, particularly in children where the bone is even thinner, the purulent infection can easily erode, perforate, or spread via venous channels across this paper-thin barrier. The infection spills into the orbit, causing orbital cellulitis.
And what does that look like?
It is a severe, sight-threatening, and potentially life-threatening emergency. The patient presents with proptosis, a bulging eyeball, severe pain with eye movement, and swelling of the conjunctiva. The infection is no longer contained within the respiratory tract. It is actively threatening the visual apparatus and has a direct path toward the optic nerve and the brain.
It is a sobering reminder of how tenuous the boundaries in the head truly are. Which brings us to the convergence of all these systems. Section 4. The integration of air, blood, and sensation. We have mapped the empty spaces and their borders. Now we must examine the immense physiological webs woven across them. The nasal cavity is one of the most heavily vascularized regions in human anatomy.
It requires immense blood flow to fuel the thermal radiator function of the turbinates we talked about. The blood supply is an extensive anastomosis, a massive interweaving of vessels drawing from three distinct major arterial sources: the facial artery, the ophthalmic artery, and the maxillary artery.
This dense vascularity creates a highly specific vulnerability that almost every human being has experienced firsthand. Epistaxis, the common nosebleed.
Epistaxis is incredibly frequent, and while it can appear dramatic, the vast majority of cases originate from one highly specific, highly exposed anatomical coordinate known as the Kieselbach area.
Where exactly is the Kieselbach area?
It is located on the anteroinferior region of the median nasal septum. If you pinch the soft, fleshy lower part of your nasal septum just inside your nostrils, you're compressing it. This localized region is the site of a grand arterial anastomosis. Four major vessels converge and physically intertwine within the mucosal tissue right here.
Which four?
The septal branch of the superior labial artery, the anterior ethmoidal artery, the nasopalatine artery, and the greater palatine artery.
Four major rivers of blood colliding in a delta just millimeters beneath a fragile mucosal surface.
It is an area of intense hemodynamic pressure, and structurally it's uniquely vulnerable. Because of its anterior location, it is constantly exposed to the drying effects of inhaled environmental air, which can desiccate and crack the delicate mucosa. Furthermore, it is situated perfectly to receive mechanical trauma, a direct blow to the face, forceful nose blowing, or the ubiquitous habit of digital manipulation or nose picking.
Right.
When the thin mucosal covering is breached, this high-pressure arterial junction bleeds profusely. Fortunately, its anterior location means it is usually easily accessible and can be controlled by applying direct sustained pressure or anterior nasal packing.
The text notes that not all nosebleeds are easily reachable, though. Sometimes the source is buried deep in the cavity.
Posterior epistaxis is a significantly more severe clinical entity. These bleeds typically involve major arterial branches, like the sphenopalatine artery located deep within the posterior nasal fossa. They are completely inaccessible to simple pinching.
So where does the blood go?
The blood often flows rapidly backward into the nasopharynx, causing the patient to swallow large volumes of blood. That leads to nausea, vomiting, and a masked assessment of total blood loss. Controlling posterior epistaxis often requires complex medical interventions, including inflatable posterior balloon catheters or endoscopic surgical ligation of the offending artery, as the patient is at risk of profound hemodynamic compromise.
The arterial side of the web is prone to dramatic rupture, but the venous side of the head and neck harbors a much more insidious, silent danger. This brings us back to the horror story from our introduction, the concept of valveless veins.
This is an architectural reality that dictates the pathophysiology of head and neck infections. The venous drainage of the nasal cavity and paranasal sinuses is accomplished via a network, including the anterior and posterior ethmoidal veins, the sphenopalatine vein, and the vein of the foramen cecum. These vessels eventually drain into larger venous pools like the ophthalmic veins, the pterygoid plexus, and the superior sagittal sinus.
It's a massive network of return pipes. But what makes these pipes uniquely dangerous compared to, say, the veins in my arm or my leg?
In the peripheral limbs, your veins are equipped with internal one-way valves. These valves ensure that blood only flows in one direction, back toward the heart, even when fighting against gravity. In the head and neck, particularly in these deep facial networks, the veins are generally valveless.
Without valves, how does the blood know which way to go?
It relies entirely on pressure gradients. Blood flows from areas of high pressure to areas of low pressure. Because there are no physical valves blocking reverse flow, the direction of transit can reverse entirely if the pressure dynamics shift. Blood can flow forward toward the jugular system, or it can flow backward deep into the skull.
And why is backward flow a potential death sentence? Let's connect it to the pimple.
Consider the danger triangle of the face, the area encompassing the upper lip, the lateral nose, and the nasal bridge. If a patient develops a localized infection here, a severe furuncle, an infected piercing, or even a violently manipulated pimple, the bacteria enter the venous capillary beds. Because there are no valves forcing that venous blood down toward the body's main circulation, the infected blood can be pushed backwards through the facial vein, into the ophthalmic veins, and directly into the dural venous sinuses located inside the cranial vault.
The infection bypasses the body's systemic immune filters and takes a backdoor highway straight to the brain.
Specifically, it frequently drains backward into the cavernous sinus, which is a massive pool of venous blood situated right at the skull base, intimately surrounding the internal carotid artery and several critical cranial nerves.
And if bacteria get in there,
If pyogenic bacteria pool and multiply in this sinus, they trigger cavernous sinus thrombosis, the formation of a massive infected blood clot within the skull. This is a devastating complication. Patients develop severe headaches, high fevers, bulging eyes, and paralysis of the eye muscles as the cranial nerves are compressed by the clot. Without aggressive intravenous antibiotics and anticoagulation, it rapidly progresses to fatal meningitis or brain herniation, all originating from a minor skin infection that exploited the valveless architecture.
the simple lack of a tiny microscopic flap of tissue, a one-way valve, fundamentally alters the mortality risk of a spot on your nose. It is the fragility of the system laid bare. We see a parallel fragility in the neural web. We discussed the trigeminal nerve providing sensory input from the mucosa, but the sense of smell relies on a different pathway entirely.
Olfaction is a special sense, mediated by the olfactory nerve, cranial nerve 1. These specialized olfactory receptor neurons are embedded in that yellowish-brown mucosa at the very roof of the nasal cavity. The axons from these neurons must travel from the inside of the nose upward into the cranial cavity to reach the olfactory bulb of the brain.
They have to cross the bony roof we discussed earlier, the cribriform plate.
Yes. The term cribriform translates to sieve-like. To allow these delicate neural filaments to pass, the horizontal plate of the ethmoid bone is perforated with dozens of tiny holes, resembling a colander. It is a highly porous, incredibly fragile shelf of bone.
And this sieve-like structure creates our final and perhaps most dramatic clinical correlation involving severe facial trauma.
If a patient sustains a high-velocity, direct physical blow to the bridge of the nose or the midface, such as striking the steering wheel in a motor vehicle collision, or suffering a severe blow in a physical assault, the kinetic energy is transmitted backward into the skull base. The fragile, perforated cribriform plate is highly susceptible to fracture under these forces.
When a bone breaks in the arm, it's a localized injury. But when the cribriform plate shatters, it breaches a critical barrier.
It compromises the structural integrity of the central nervous system enclosure. The olfactory bulb, and more importantly, the meninges, the thick protective membrane layers encasing the brain, are tightly adherent to the superior surface of the cribriform plate. When the bone fractures and shifts, it almost invariably tears the meninges,
Creating a leak.
This traumatic laceration creates a direct physical communication between the subarachnoid space, which contains the cerebrospinal fluid bathing the brain, and the unsterile environment of the nasal fossa.
The seal is broken. The fluid leaks out.
The clinical presentation is known as cerebrospinal rhinorrhea. The patient may present in the trauma bay with what appears to be a continuous, profuse runny nose dripping clear, watery fluid from the nares. But this is not mucus. If the fluid is collected and tested, it will be positive for glucose and beta-2 transferrin, confirming it is pure cerebrospinal fluid draining directly from the cranial vault.
The loss of fluid is concerning. But the real terror is what can travel up that open pathway, just like the extracted tooth scenario.
The flow goes both ways. A cribriform plate fracture creates an open tunnel for the aggressive bacterial flora of the nasal cavity to ascend directly into the cerebrospinal fluid. The risk of developing rapid, fulminant, and potentially fatal meningitis is astronomical. It requires immediate clinical recognition, strict avoidance of any nasal manipulation or packing, prophylactic broad-spectrum antibiotics, and frequently neurosurgical intervention to physically patch and seal the dural tear.
Structure in service of function, leading to structural failure, resulting in absolute catastrophe. We've journeyed through the hidden server rooms, navigated the aerodynamic baffles, mapped the evolutionary flaws of the sinuses, and traced the perilous valveless highways to the brain. It is time to synthesize this immense architectural blueprint and test your spatial reasoning.
Yes, to solidify these anatomical relationships and their clinical implications, we must engage in active, applied recall. We will present a series of clinical and anatomical scenarios. Listeners, I challenge you to visualize the spaces, trace the pathways, and deduce the answers before we break down the underlying logic.
Let's test the mental model. Question 1. A surgeon is operating deep within the face and needs to locate the primary neural hub that controls both the sensory input from the upper teeth and the secretomotor output for the lacrimal gland. Which of the following nerves enters this specific hidden space? The Pterygopalatine Fossa via the foramen rotundum. A, the ophthalmic nerve, V1. B, the maxillary nerve, V2. C, the mandibular nerve, V3, D, the facial nerve, CN7.
This scenario demands precise knowledge of the fossa's entryways. The correct answer is B, the maxillary nerve, V2. As we established, V2 departs the middle cranial fossa and transits perfectly through the circular foramen rotundum to enter the posterior aspect of the Pterygopalatine fossa.
And why not the others?
To eliminate the distractors, the ophthalmic nerve, V1, bypasses this space entirely, entering the orbit through the superior orbital fissure. The mandibular nerve, V3, drops out of the skull via the foramen ovale. And crucially, while the facial nerve does provide the parasympathetic fibers to the ganglion located here, its main trunk does not enter via the foramen rotundum. Its specialized fibers arrive via the entirely separate pterygoid canal.
Moving to the paranasal spaces. Question 2. A pediatric patient presents to the emergency department with a severe, untreated ethmoidal sinusitis. The child's right eye is bulging outward, red, and intensely painful to move. The infection is spread beyond the sinus. What adjacent anatomical structure is immediately threatened due to a shared paper-thin bony separation? A, the frontal lobe of the brain, B, the oral cavity, C, the orbit, D, the sphenoidal sinus.
This tests the three-dimensional boundaries of the sinus cavities. The correct answer is C, the orbit. The lateral wall of the ethmoidal labyrinth directly forms the medial wall of the orbit. This separating bone is the laminopapyracea. In aggressive infections, particularly in children, this fragile barrier is easily breached by purulent material, leading directly to orbital cellulitis, which perfectly matches the presentation of a bulging, painful eye.
And the other options are just anatomically too distant.
Right. While fulminant sinus infections can eventually reach the brain, option A, the direct lateral anatomical adjacency to the orbit, makes it the primary and immediate catastrophic risk specific to the ethmoidal cells. And the oral cavity, option B, shares a boundary with the maxillary sinus, not the ethmoid.
Question 3. A patient sits in a dental clinic in agony, complaining of a throbbing toothache in their upper right jaw. The dentist performs a comprehensive exam and takes radiographs, revealing that all the maxillary molars are perfectly healthy, with zero signs of decay or localized infection. The dentist suspects referred pain, inflammation of which of the following spaces is the most likely underlying culprit? A, the frontal sinus, B, the sphenoidal sinus, C, the maxillary sinus, D, the Pterygopalatine fossa.
This is a classic diagnostic trap rooted entirely in shared neural wiring. The correct answer is C, the maxillary sinus. The floor of the maxillary sinus is intimately related to the roots of the upper molars. Both the mucosal lining of the sinus floor and the dental pulps of those specific teeth receive sensory innervation from the exact same cable, the posterior superior alveolar branches of the maxillary nerve, V2.
So brain gets confused.
Exactly. When the sinus mucosa is highly inflamed and swollen due to sinusitis, the barrage of pain signals traveling up this shared pathway is misinterpreted by the brain as originating from the teeth, resulting in a phantom toothache.
Let's examine facial trauma. Question 4. Following a violent bar fight involving a severe direct blow to the midface with a blunt object, a patient is observed in the trauma bay to have a continuous, watery, clear fluid leaking from their nose. A quick bedside test confirms the fluid contains glucose. Which precise bony structure has most likely been fractured to produce this specific clinical sign? A, the paranasal bones, B, the perpendicular plate of the ethmoid, C, the cribriform plate of the ethmoid, D, the palatine process of the maxilla.
The clinical sign here is cerebrospinal rhinorrhea, a critical emergency. The correct answer is C, the cribriform plate of the ethmoid. The presence of glucose indicates the clear fluid is cerebrospinal fluid, not nasal mucus. The cribriform plate is the fragile, highly perforated central roof of the nasal cavity.
Right, the sieve we talked about.
Yes. It supports the meninges and the olfactory bulb. A fracture here violently tears the adherent meningeal layers, opening a direct fistula between the subarachnoid space surrounding the brain and the unsterile nasal cavity, allowing CSF to leak out and bacteria to potentially enter. While the external nasal bones and the septal perpendicular plate are undoubtedly broken in a severe midface smash, only a fracture traversing the skull base, specifically the cribriform plate, will result in a cerebrospinal fluid leak.
Let's trace the blood. Question 5. A teenager arrives at the urgent care clinic with a severe, uncontrolled nosebleed that the physician localized to the Kieselbach area on the anterior portion of the nasal septum. The physician applies targeted pressure to stem the massive flow. Which of the following arteries does not contribute to the vascular anastomosis in this highly susceptible region? A, septal branch of the superior labial artery, B, anterior ethmoidal artery, C, infraorbital artery, D, greater palatine artery.
This question requires the precise unraveling of the vascular web we mapped. The correct answer is C, the infraorbital artery. The Kisselback area on the anterior septum is defined as the convergence point of four specific vessels: the septal branch of the superior labial, the anterior ethmoidal, the nasopalatine, and the greater palatine arteries.
And the infraorbital is doing something else.
Right. The infraorbital artery, while it is a major continuation of the maxillary artery, travels through the orbital floor to emerge onto the face, supplying the lower eyelid, cheek, and upper lip. It does not send medial branches onto the nasal septum to participate in this specific vulnerable plexus.
And our final challenge, question 6. We detailed the complex, almost deceptive routing of the autonomic nervous system in the deep face. The secretomotor fibers responsible for actively stimulating the mucosal glands of the nasal cavity to produce their liquid secretions originate fundamentally from which cranial nerve? A, the trigeminal nerve, C and A. B, the facial nerve, C and A. C, the glossopharyngeal nerve, C and X. D, the vagus nerve, C and X.
This scenario tests the critical distinction between the physical anatomical highway and the physiological origin of the command. The correct answer is B, the facial nerve, C and Zeph. The parasympathetic preganglionic fibers that carry the secrete command originate with the facial nerve. They navigate the pterygoid canal and synapse within the pterygopalatine ganglion.
The hitchhiking concept.
Exactly. It is vital to understand that while the trigeminal nerve's maxillary division, V2, provides the physical pathways, the sprawling branches, for these postganglionic fibers to finally reach the nasal glands, the trigeminal nerve itself does not generate the secretomotor command. The trigeminal is purely sensory. The facial nerve is the master conductor of the secretion.
That concludes our rigorous anatomical interrogation. As we pull back from the microscopic foramina and the turbulent airflows, I want to leave you with a final thought to mull over. We've spent this entire session analyzing the staggering complexity of this hidden architecture. The aerodynamic baffles of the turbinates warming the air, the precisely routed neurovascular cables utilizing shared bony tunnels, the intricate mucociliary clearance mechanisms. It is a marvel of biological engineering that allows us to draw a breath of freezing air and render it perfectly safe for our delicate lungs in a fraction of a second.
Yet it is that exact same intricate, highly adapted architecture that defines our greatest physiological vulnerabilities.
The human face represents a terrifying evolutionary trade-off. To possess this beautifully complex, lightweight system capable of warming the air and detecting microscopic scent molecules, we had to construct a skull full of hollow voids, a venous network devoid of protective valves, a drainage system that defies gravity, and bony walls as thin as paper separating the outside world from our visual and neurological centers. We are built for extraordinary function, but the blueprints of that design create permanent hidden pathways. A minor shift in a cartilage septum, a closed microscopic drain hole, or a minor skin infection on the nose always possesses the latent, chilling potential to bridge the gap and touch the brain itself. Our greatest evolutionary adaptations are inextricably, permanently linked to our most catastrophic structural flaws. Something to ponder the next time you feel a simple sneeze coming on.
A sobering but profoundly accurate assessment of the anatomy.
Here are the details of this episode.
Pterygopalatine fossa, nasal cavity and paranasal sinuses, the hidden corridors of air and flow. Byline: a silent crossroads where air, sensation, and secretion converge, hidden pathways shaping breath, voice, and vulnerability.